In this country and around the world, we are facing an epidemic of autism and a host of pediatric mental health conditions. We are seeing this epidemic of anxiety and aggression and irritability that was never there before. We're seeing children struggle to learn in schools to the point where the schools are completely overwhelmed in their ability to take care of these children. And everyone keeps talking about environmental factors, yet I would argue that the most significant and dangerous environmental factor, which is mold toxicity and dampness, which constitutes a host of other things, is the number one environmental factor that is driving this epidemic of pediatric mental health and autoimmunity. You see, it's so easy to miss this because providers don't know how to test for it. And because of that, it's commonly missed on diagnostic testing. Unless you have a environmental expert that is very well trained and highly capable of searching, you can miss it in the environment. And I've had hundreds upon hundreds of families that have come in. Oh yeah, we tested our house. We tested our house twice. We don't have mold. And sure enough, there was significant mold in the child's bedroom that was causing them to be sick, but it was missed. This is how problematic and misunderstood this entire domain is. And the purpose of this discussion and presentation is to help empower providers to become more effective in understanding how to identify it and also treat it in their patients. I have to start with this disclaimer that this is strictly for educational purposes. Any patient who child is struggling needs to find a provider that is qualified to be able to help them. And in no way, shape, or form does this establish any kind of patient-physician relationship just through this presentation. One of the things that's really important for everyone to understand is when we talk about mold, really what we're talking about is dampness, which is some kind of indoor water event or moisture problem. And when that water event occurs, it's never one type of mold. It's never one type of mold toxin. In fact, it's not just even the mold toxins. There are bacterial endotoxins. There are microbial volatile compounds, microbial organic compounds, a host of different things that are being released into the environment. And as you see in this study right here, we're frankly barely starting to understand what these compounds are and exactly what they are doing. What we do know is that in combination, these toxins, these environmental toxins, are capable of causing harm at very, very low concentrations. And this is the part that's oftentimes completely overlooked by the medical community because they look at one mold spore or one mold toxin and they say, well, this toxin didn't cause illness in this population in this concentration, even though they only studied it for 12 hours and they only studied one toxin. Also, because environmental experts, or I should say environmental inspectors, most of whom are not certified, most of whom do not have adequate amounts of training, are essentially looking for catastrophic water events where your ceiling is about to collapse and anything outside of your ceiling collapsing to the point where you don't need an inspector to tell you there's an issue, they're missing. Why? Because their mindset is unless something is catastrophic, it is not a problem, which is similar to our mindset in conventional medicine. Unless there's some kind of dire, catastrophic thing, it is not a problem. And this is why it's getting missed all the time. And I'll talk further about how it's getting missed in diagnostic testing. This is just a sampling of all of the things that these environmentally induced toxins can cause. They can cause cerebral folate deficiency, which we know is a part of autism. It can change brain chemistry. It can trigger quinolinic acid, which can cause extreme aggression. It can change dopamine levels, norepinephrine levels. It can change oxytocin. It can change serotonin. So sociability. It can change sensory pathways. So for those poor kids who are overwhelmed in the world, they have sound sensitivity. They can't tolerate clothing. They can't tolerate their hair being washed. They're extremely picky in their eating. These are all signs of dampness and mold-related toxicity. Neuroinflammation is extremely common. Mycotoxins have been found to trigger microglial activation directly through inhalation. You can get mitochondrial dysfunction because these mold toxins in particular, the mycotoxins, are highly toxic to the mitochondria. They can trigger mast cell activation. Mycotoxins and molds have been shown to trigger mast cell activation. Forget about everything else that is released into the environment. And this is just the tip of the iceberg. What creates a more significant problem is this notion of combined toxicity. And the reason why mycotoxins are becoming a bigger problem now than ever before is, one, building standards have changed. So buildings are not built to the same quality as they were 30 years ago. Drywall is relatively new, and drywall, as soon as you add moisture to it, it gets moist and starts creating mold and dampness. We also have sealed our buildings. So the way homes used to breathe 20 years ago, they don't anymore. So that constant air exchange that actually used to dilute these toxins is no longer taking place. Furthermore, as you add all of the other environmental factors, processed foods, heavy metals, glyphosates, COVID, air pollution, you have increased vulnerability within the human system. So human beings, not only are we having more exposure, as human beings, physiologically, we are more vulnerable to dampness and mold-related toxicity than ever before in the history, I would argue, in the history of mankind. We have essentially created this dangerous and concerning experiment where we have introduced a host of variables into our environment and our food supply, which has degraded and created susceptibilities within the human body that makes it less resilient in handling things like mold and mold toxins. And ultimately, what we get is this, where there are a handful of exposures early on that create susceptibility. There's already vulnerability within the gut. You get an excessive toxin load, including these indoor environmental toxins that basically throw the gut into a perpetual state of inflammation. And then once that happens, a host of other things now become tertiary problems. And this leads to mast cell activation, microglial activation, which causes a horrendous amount of inflammation in the nervous system. And that has been shown to be tied to autistic features. And you also get endotoxemia, which is basically the toxins that the bacteria produce from within our gastrointestinal tract are now being released into the bloodstream, going into the nervous system, causing horrendous amounts of inflammation and toxicity in the nervous system. And if you want, just go type in bacterial endotoxins, neurons, bacterial endotoxins, Alzheimer's, bacterial endotoxins, autism, bacterial endotoxins, Parkinson's, and you'll see this plethora of information that is looking at these bacterial endotoxins with this microglial activation, the brain toxicity, as part of the primary driver of most psychiatric illness, including autism. For those of you that want a detailed dive into this discussion, I suggest that you look at this video on this YouTube channel. It gets into all of the various mechanisms that create the susceptibility and drive the inflammation within the gut. That's not the purpose of this discussion. What about binders? Patients constantly ask me, well, Dr. K, don't you use binders? What about binders? We've heard binders are so helpful. I have no question, there is no question that binders can be helpful. And I certainly believe that in adults, they can make a world of difference in helping with all of the inflammation and toxicity that they have. But when you really drill into this entire concept, there are weird nuances that come up, such as in mammals, they have found that these mycotoxins in particular only last for a few hours. They're actually biodegraded within the human body or within the mammals. So if these toxins essentially disappear on their own after a few hours, what exactly are we treating? And why do people get better with binders? But what is actually driving the toxicity years later? And when you look at some of the literature, what you find is yes, the binders are helping, but they're helping for reasons that are actually different than what we always thought. Because I was trained to look at these charts and say, oh, well, someone has ochratoxin, and because they have ochratoxin, then I will use this or this to help. I never noticed how these binders, and I've added some literature that suggests that bentonite clay, activated charcoal, chlorella, a host of things are actually binding these bacterial endotoxins. And if you go back to this chart, yes, you could bind these toxins to help improve physiology. You can help people feel better. But wouldn't it make more sense to address the rest of this cycle? Wouldn't it be more helpful to address this inflammation, address this gut permeability, address this dysbiosis? And really, the purpose and whole focus of this discussion is how do we take care of those things to actually address the physiological root cause of the toxicity that is driving most of the conditions that we see. So this is the total protocol, and all of this is available online for you to look at. So first and foremost, it's finding the right patient to apply this to. Randomly applying this protocol to patients who may not have this related exposure may not necessarily be helpful, and we'll talk about that. What you see is immediately there are two things that need to happen at the same time. There is the start of the anti-inflammatory protocol, which we'll discuss, but simultaneously, immediately focusing on the environment. What I have found in now over 1,000 patients and now 8 years of treating these patients is when there's significant ongoing exposure that is not addressed, that is missed, that's like having a boat where there's a gaping hole in the side of that boat. You're constantly bucketing out the water and not understanding why you're continuing to sink. And I've had many second opinion consults where the provider did everything right. Everything right. They used the right medications, they used the right treatments. Everything was perfect. The one thing they missed was the environment. Because they relied on the misinformation that the family received from a random mold inspector that probably did not have adequate training. And therefore, the family misunderstood the exposure. They were essentially lied to that there was no exposure, and the family relayed it to the physician. And this was happening to me early on. I would rely on the word of the family where they would say, oh, we don't have mold. We've been tested. Okay. And you move on. And I learned the hard way after multiple patients failing that I had to be the one to actually help guide the family in their exposure. Now, physicians are not meant to be environmental experts, but they do need to be the stewards of their patient's health. And if that means helping the family truly and accurately assess their environment, then so be it. And this is where the dust test comes in. I have no affiliation with them. The reason why I've come to like them is they make it simple. And as a screening tool, so the dust test is not meant to confirm there is exposure, but it is a screening tool to help families understand what is the probability of exposure. It's a simple ERMI test. So basically, it's a little Swiffer pad you get. You go around your house, you gather dust, and you send it off. And they run a DNA probe on this dust to tell you if there's weird fragments of molds that don't belong inside a house. Because it's true, all homes have mold. Homes should not have toxinogenic molds. Stachybotrys, Chetomium, certain strains of Aspergillus, certain strains of Penicillium only grow inside a damp environment. And when those molds that are highly toxic are present, the likelihood of a water event that has been missed goes through the roof. And the beauty of the dust test is it makes this very simple. It comes with very adequate instructions. And one of the things I tell families in advance is when you order the test, just don't have anyone or you yourself, don't dust the home, don't clean the home, tidy the home, but leave the dust and allow it to settle because what you're sampling is that dust. And if there's not enough dust, you get an inaccurate response or sampling. And basically, you get one of three scenarios. You get a code 1 through 3, and if there was an adequate amount of dust, it becomes fairly accurate, which means that, you know what, the likelihood of some kind of active event is no longer the case. And this is a scenario where the family may have had exposure in the past. The child may have had exposure in schools. 1 in 5 classrooms have mold. The child may have had exposure at grandma's house. I've seen it at gymnastics gyms. So that code 1 through 3 is generally a good sign. Code 4 is basically from 50th percentile of contaminated homes up to 90th percentile. So there's a huge range. And a code 4 doesn't necessarily mean there's a guaranteed problem, but it also doesn't rule it out. And a code 5 generally means that there's a high likelihood of an issue, in which case a qualified mold inspector or environmental expert needs to step in to guide the family. We inspect, the parent company of the dust test has these teams, and there's a website called iseai.org that has a wonderful list of other environmental experts who are highly qualified and capable in helping. One of the things that's important is with the code 5, it doesn't mean you cannot help someone. I believe you still should and can help. The reality is, if the exposure is significant enough, until that exposure is controlled, the likelihood of really good, highly effective outcomes are low. There are air purification systems that can be used. One of my favorites, I have no financial affiliation with them, is Air Oasis. They have a air purifier that has a carbon filter, HEPA, and ionization in one. There are deep cleaning protocols that can be used that can generally help. But the problem is that if there's a severe exposure in one area, that may still not be enough. This takes us to the next part of the protocol, which is basically this first anti-inflammatory phase, and we're going to expand on this. The anti-inflammatory phase is a combination of a handful of simple supplements that are meant to reduce brain inflammation. And this becomes a way to improve symptoms. So irritability, sensory processing, sensory issues, aggression, etc., sleep problems, all can improve through this. Now, part of why we do this is not just to improve symptoms. It actually becomes a way to have providers sense the degree of imbalance that's there. Because if the patient does not improve, that takes us to looking at what else may be going on. Some of these patients have frank autoimmune disease, they have frank lupus, they have frank thyroiditis, they have co-infections of Lyme disease, they have severe anemia, have zinc deficiency, and I've seen all of this. Some of them have severe parasitic infections. And sometimes until you address that, presuming the environment is not an issue, the patient can't move on. If there isn't a significant environmental exposure and there are no other significant, including dietary factors, kids with food allergies, high food sensitivities, eating lots of gluten and dairy, you cannot overcome that through supplementation. If the patient has a good response, then we move on to nystatin. Why do we do nystatin before itraconazole? Again, we're using nystatin not just to treat, but to also assess the child's system. 20% of children on nystatin will improve. Children with autism will start making more eye contact. They'll be more calm. They'll be more engaged. 40-50% experience no change, which is fine. 20%, the most highly sensitive, those are children, typically the children who are most highly dysregulated, will not tolerate nystatin. That is a sign that within the gastrointestinal tract, there is such a degree of dysbiosis, imbalance of the bacteria and fungi, and likely such high degree of gut dysregulation, gut immunological dysregulation, that this simple, safe antifungal is causing a problem. And these are typically the children who would do very poorly with itraconazole. These are the children that if they're reacting to nystatin, if you were to put them on itraconazole, they will go into a complete flare. I've seen children have extreme anxiety events, aggression, irritability, insomnia, etc. And those are the children that are not ready. Not doesn't mean that they can't handle it. It doesn't mean they shouldn't have it. It just means that they're not ready because their system is not in a place where they can handle that kind of intensive therapy. And for a detailed discussion around itraconazole, there's additional resources and presentations that I'll share with you. Presuming there is no environmental trigger and these factors, including dietary factors, are addressed, if a child is not responding to nystatin, one of the things that I have found to be helpful are peptides. I'm not going to get into that in detail. There are many wonderful experts and courses that are out there that can discuss this in detail. What I can say is, from what I have learned, lorazepam and KPV are two peptides that work wonders for improving gut permeability, improving gut inflammation, which oftentimes is what's needed to then allow nystatin to be reintroduced. And generally speaking, after no more than 2 months of these peptides, the children have immunological tolerance to nystatin, which then allows them to be ready for itraconazole. One of the things I want to add about nystatin is the children who are highly, highly sensitive usually do not tolerate regular prescription nystatin. If you're welcome to go look at this, and we'll touch on this in a second. Prescription nystatin has food colorings, it has flavorings, it has various preservatives, which make it highly immunogenic to the gastrointestinal tract. Local compounding pharmacists can compound nystatin without those additives to make it better tolerated. If a child tolerates itraconazole, and you'll see that in their neuroinflammatory response, the children will be more calm, they'll be more grounded, they'll make more eye contact, their sensory issues go way down, their sleep improves. They're more comfortable in their own skin is really a way to put it, and they are way more regulated. When that happens, I believe that is the time to introduce all of these other therapeutics. For children who have intense dysregulation, I've seen them be in 2 years of occupational therapy, and they have made barely any gains, whereas once they're calm and regulated and present, I've seen children make more gains in 2 months of OT than 2 years of OT before. I highly believe in all of these treatments. I believe that occupational therapy, physical therapy, applied behavioral analysis, speech therapy are all wonderful therapeutics. I did it for my daughter. I actually did occupational therapy for myself. And sensory integration, all of that work is tremendous, but the child needs to be ready. They need to be capable. They need to be present to be able to receive it. And we are spending a lot of resource trying to do therapy on children whose systems are completely inflamed and frankly, completely upside down. These children are struggling. They're struggling to be in the world. They're struggling to function. And those are the children that typically do not make much progress when they get these kinds of therapeutics. I believe folinic acid and leucovorin and metabolic support are game changers for children on the spectrum, no doubt. Improved receptive language, improved eye contact, improved expressive language, all kinds of amazing things can come from that. What I've also found is when these children are in an acute inflamed state, aggression, irritability, cannot focus, can just are dysregulated, all over the place, hyperactive, intense sensory issues. When you add the mitochondrial support or folinic acid to that, oftentimes I'd say 50% of the times these kids will flare. And what you get is a child that's even more dysregulated, more aggressive, more irritable. And that's because their chemistry was already off. They have quinolinic acid in their nervous system. They have dysregulation where there's too much dopamine, too much norepinephrine to begin with. And when you add methylation support, you're boosting these same chemicals, which causes the person who's already anxious and hyper to essentially explode. So it's a different way of approaching the care of these children. And it makes sense. When you just look at it, it just makes sense. Yes, it would make sense to have a child's system not be inflamed and neurologically have that child be more calm to be able to receive all of these other remarkable therapies. So what's next? And I'm just going to touch on one thing over here. There are times where with a code 1 through 3, or even a code 4, you find that these children are still struggling. And sometimes what happens is we test a home, the home was fine, but the school is the issue, or the gym was the issue, or grandparents' home was the issue. So one of the things that's important, and you'll see as part of this protocol, is to think outside of the box and don't get so myopic of like, oh, this is always the home. If the children are doing well, the likelihood of a problem is less. If the children are struggling and you keep hitting walls, you need to go back to the drawing board and ask, what have I missed? And I've had many cases where you look and it was the classroom. There was one case that we had where 5 children in a classroom of 20 something were having aggressive neurological issues, PANS and PANDAS, anxiety disorders, learning disabilities. 2 of the kids were having asthma attacks left and right. One of them kept getting ear infections. If you see that pattern, that's because there's some environmental factor within the classroom causing that cohort of individuals to struggle. All of this is detailed in the rest of this presentation. And the full protocol can be found on this Substack post. And a detailed discussion around itraconazole can be found in this presentation. So how do we identify the right patient, right? That's one of the first things. If you work with enough of these patients, and for those parents who are looking at this, the patterns become clear once you start seeing them, because it's never one finding. It's never one thing that says, oh, this is mold. It's a constellation of findings, such as if the child was born in a damp environment, right, versus the child was fine, but then at 3 years of age suddenly started falling apart. Obviously, a different time of exposure, right? So in this case, if the child is born into a damp environment, these are kids that have significant colic usually from day 1, within the first week of life, whereas conventional colic doesn't typically show up until 2.5, 3 weeks of life. These kids start developing colic and you see, or reflux, and you see the colic, normal colic typically ends at 3 months of age. This type of colic can sometimes go on for 6 months, 9 months. I've had families that look and they're like, yep, my kid was born a terrible sleeper and they had colic, and that terrible sleeper kind of didn't go away until 2 years of age. That is a sign of neuroinflammation. Reflux that doesn't go away after 6 months, where now you're putting them on Pepcid or PPIs, that's a sign of gut inflammation. Eczema, allergies that show up in the first year of life is a sign of gut dysregulation. These things only show up when the gastrointestinal tract starts falling apart. The food allergies or sensitivities that start showing up in the first 2 years of life is a sign that the immune system is dysregulated. And one of the things that is highly capable of doing that is dampness and mold. Because there's mitochondrial issues, a lot of these children, and you see the pattern, they have all of these things together. They also have gross motor delays. They don't crawl on time, they don't walk on time. So instead of crawling at 6, 7 months, they're crawling at 9 months. Instead of walking around 12 to 13 months, they're walking around 14, 15 months. They have expressive language delays. And there is that injury. Why do these kids have these adverse reactions? Because immunologically, they're already on fire. Immunologically, metabolically, physiologically, they're waiting to fall apart. And all it takes is one thing to set them off. These are things that we're missing all the time. And when you look at these injuries, these children never were perfectly normal before. They had all these findings. And this is what I see over and over and over again in the patients that I take care of. In the older children, oftentimes we find children are hyperactive, but they lack endurance, meaning they're still hyper. They can't settle down. They can't sit down. But if they come to run for 20 minutes, they can't sustain it. They have low tone. Sometimes their muscles start getting painful with exertion. Not all, but some of the kids have poor weight gain. They have poor growth. That's about 5, maybe 10% of these kids. A lot of these kids start off as great eaters, but then by 1 or 2 years, they become more and more and more picky to the point where parents have to put a screen in front of the child and literally have to shovel food in their mouth because the child doesn't get hungry. The reason why these kids don't get hungry is the inflammation and direct toxicity from the mycotoxins can actually disrupt appetite centers. These children have sensory distortion, so their experience of food in their mouth actually causes them to experience food in an abnormal way, and that's why they become very picky eaters. There are the multiple food allergies. A lot of these children have these weird patterns where they have abdominal pain, but it doesn't make sense why, because they're not necessarily constipated, yet they can also develop constipation. And one of the things you see, there are specific bolded things. I'd say about 10 to 20% of these children have an abnormal pattern of cavities. They develop multiple cavities. Why? Because their gastrointestinal tracts are inflamed and their ability to absorb minerals and also vitamin D receptors are distorted. So their way of managing calcium and a host of other things are disrupted. On stool testing, sometimes you see elevated secretory IgA, sometimes, maybe 10 to 20% of the time, you'll see elevations of candida. These children have allergies because it turns out that the bacterial volatile compounds in the microbial particulates are highly inflammatory to the ENT sphere. So these kids get chronic congestion. They have chronic mouth breathing. One of the things that I see as a significant sign is enlarged tonsils or adenoids. The only thing that I've seen, at least in my Southern California population, that causes enlarged adenoids and tonsils is dampness because of these microbial particulates. These kids have chronic congestion after viral infections, and the parents are like, yeah, he got a cold and 3 weeks later he's still coughing or he's still congested. And because they have so much inflammation in the ENT sphere, they get recurrent ear infections. Again, it's never one thing. Just because a child has recurrent ear infections, that doesn't mean they have mold. But if that child also has some attention problems and some focus issues and some sensory issues, and they have some sleep issues and they have some digestive problems, at a certain point, that constellation of findings becomes more and more suggestive of mold. Never 100%, but more and more suggestive. Because these particulates, these microbial particulates, are also highly inflammatory to the airways, and there are multiple animal studies that have shown this. These children have these weird respiratory issues where they get a cold, but they've got severe asthma and they're ending up in the hospital. A 3-year-old, 4-year-old, 5-year-old, 8-year-old gets croup. And the croup gets so bad because of RSV that they also end up in the hospital because they just cannot stop coughing. It's reasonable for a 6-month-old to get RSV and have severe coughing to the point where they can't breathe. It's not reasonable for a 3-year-old or older child to have such severe airway inflammation. That's not normal for those kids to end up in the hospital. Again, the asthma with severe viral induced airway reactivity, that is something that is highly suggestive of dampness. These kids are very poor sleepers. Their adrenaline levels, their histamine levels, which disrupt their arousal centers, are so high. It's like the child has had 15 cups of coffee and they can't settle down. Some of these kids, you give them melatonin, you give them magnesium, they fall asleep, but then only wake up at 2 to 4 in the morning. These are all signs of exposure. You get dermatographia, where the child gets touched and then turns red. They touch grass, their skin turns red. These are all signs of excess histamine because of mast cells. The intense swelling to insect bites is another sign of excess histamine due to mast cells. The severe eczema, that has to do with the gastrointestinal tract losing its integrity. These are all things. And again, when you look, there are constellations of these. There are larger patterns. It's never, oh, the kid just has an insect bite that becomes a problem. Usually they're also hyperactive and they're distractible and they're inattentive and they have memory problems. And yeah, they also have constipation and they're kind of a picky eater. Neurologically, one of the things that I see are tics. And there's a really beautifully written article by Dr. Andrew Campbell that talks about how EEG abnormalities, tics, and seizure-like episodes have been tied and shown to be much more prevalent in individuals who have been exposed. Because of the fact of what histamine does to the sensory pathways, you get all kinds of weird sensory findings. Places are too loud. The kids that can't stop moving, that's a vestibular finding. The tactile sensitivity, the kids that can't handle clothing, that can't handle their hair being washed, can't handle water in their face, they can't handle the feeling of sand. Those are all abnormalities in sensory pathways because of inflammation from this exposure. These kids are clumsy. They have poor motor planning. And one of the other things that I should actually have highlighted is this irrational fear. When you have inflammation in the nervous system, you get a very distorted perception of reality where seemingly benign things that are inconsequential are deemed as threats to the nervous system. When you see that, you need to ask not just, oh, what's driving this inflammation, or is this inflammation? You need to ask, what is driving this inflammation? Lyme and Lyme co-infections can absolutely cause many of these things. Lyme and Lyme co-infections do not cause allergies. They do not cause airway inflammation. They do not cause gastrointestinal issues to the same extent. They can cause some abdominal inflammation, but not to the same extent. And what we also find are weird patterns of anxiety, including separation anxiety. We get learning disabilities where these kids are highly distractible, highly impulsive. They're struggling to learn. They're struggling to focus. They have problems with working memory. So when it comes to learning math concepts, these kids can't retain math concepts for the life of them. You have to have the same thing repeated multiple times. And it's like, what the hell? I just explained this to you. Why can't you learn it? It's because literally the RAM, if you want to look at it, the human mind as a computer, the RAM that's needed to store the information and process the information and file the information is completely messed up. That's what working memory is. These kids have poor executive functioning. They try to sit down to do their work, and 5 seconds later, they're off. I see visual processing errors very often in these children. They skip lines when they read. They have dyslexia. They're having a host of things. And again, you never see one thing by itself, but there's usually a larger constellation of findings together. A lot of times, some of these findings are in the child or in the patient, and some of the findings are in the sibling. So the sibling may not be the one that's the problem because they're not on the spectrum, but they have an anxiety disorder, or they keep getting ear infections, or they keep landing in the hospital because of asthma attack. And when you put this all together, again, there's only one thing that can help explain this picture, and that's dampness. In adults, moderate to severe fatigue is a common finding, and sometimes if it's in the classroom, it's the teacher, where these poor teachers are falling apart. They're constantly exhausted. They can't focus. They can't remember. Brain fog and memory changes are also extremely common. And when I do my consults with families, I look at the child and I'm like, okay, they probably have exposure. And I ask the family, like, which of you has any brain fog or fatigue? And usually, like, before I'm even done saying my sentence, there's one parent that's like, yeah, my memory has been awful. I've been so forgetful. Or, my God, I've been so tired. And I just chalked it up to being a busy parent. Adult onset asthma, chronic congestion, eczema that's coming out of nowhere, weird muscle pains. So we call it fibromyalgia. Those can all be tied to this exposure. And when you put the total picture together, it becomes something that is difficult to ignore because you'll see these show up over and over and over and over again in these patients. But we're missing it because most providers have no idea to even look for this. On laboratory findings, there's nothing that's specific. And if you just do a simple CBC with a metabolic panel, you can absolutely miss it. But what we find in 20% of these children is that there's some elevation of the liver enzymes, never frank hepatitis, never, oh my God, this is liver disease, because that's like a AST or ALT of 300, 500. But usually it's like in the 30s to 50s, maybe 60s. 10% of these kids have low white blood cell counts. Why? Because certain mycotoxins are immunosuppressive. Where do we get half our immunosuppressive medications that we use for transplants? Cyclosporin, mycophenolic acid. These are all medications that came from mold toxins. So what we get is a weird pattern of immunosuppression with low neutrophil counts, low leukocytes. RBC zinc is commonly low. Why? Because these children can't absorb minerals. So while it's not specific at all, one of the most sensitive things that I see all the time is RBC counts. Sometimes there's an RBC count of 6, whereas normal is above 9. Iron deficiency is common, multiple food allergies that discussed. And because these children have such disrupted gastrointestinal and systemic immune responses, sadly, positive ANAs are very common in these children. Again, nothing specific. You can't say, oh, because there's an AA, this is mold. But as you plug it into the bigger picture, it becomes something that is so difficult to ignore. I believe this is something that's very important to discuss. I see many colleagues in the holistic medical community using organic acids as their primary diagnostic tool to look at mold exposure. And I have to admit, 8 years ago, I was doing exactly the same thing. And it was my friend and mentor, Dr. Neil Nathan, that said, hey, Pejman, you can't rely on that test very much. And he was absolutely right. I have found that at least 50% of the time, 50% of the time, if you use a company like Genova Diagnostics or Mosaic that actually have fungal markers on their test, 50% of the time that test will miss it. If you're using Vibrant or some of these other tests, they don't even check for some of these fungal markers. So you have to be careful about what test you're using. Oxalates, when they're very high, could be suggestive of possible fungal imbalances that are because of mold. Because these mycotoxins are highly disruptive to metabolism, you can get elevations of fatty acid oxidation. You can get elevations in markers of the mitochondria. Again, nothing specific. You can't say, oh, for sure this is mold. But again, if it fits the total pattern, the child has recurrent ear infections and learning disabilities and autism, and they have elevated mitochondrial markers. There aren't too many things that can do all of that. A lot of people also use urinary mycotoxins. I believe in adults, they could be very helpful. Frankly speaking, I have entirely stopped using them because of several methodological and problems with it. First and foremost, if you go and do a literature search, urinary mycotoxins were created to assess food-related toxicity. So in countries where mold toxins are prevalent in the food, they were using this to look at food toxicity. And any toxin that's in the food can show up in the urine and actually cause a false positive. What I've also found is at least 30%, if not closer to 50% of the time, you can get a relatively normal looking urinary mycotoxin where you look at it, you're like, oh, that's not too bad. This can't be toxicity. This can't be mold. And you go and search for all kinds of other things and you miss the fact that this was mold. So because of that, I don't use urinary mycotoxins. I use organic acids with caution. I still think they're fantastic. They're helpful, but I use them with a degree of caution. What I have come to really rely on, and this was with the encouragement of my friend, Dr. Vojdani, or friends, I should say, and Dr. Campbell. So in 2003, Dr. Vojdani and Campbell et al. Published this paper where they took a large cohort of adults that were in damp environments and controls, and they found that these individuals had much higher levels of antibodies to molds versus the controls. Now, people have questioned this study. Not everyone agrees, so don't take this as, God's word. But at least in my experience of now 1,000 plus patients, it's one of the things that I have come to rely on the most. It doesn't tell you where the exposure happened. It doesn't even tell you when the exposure happened. It just says that at some point in time, there has been sufficient exposure to trigger an immunological response, which then suggests that it is mold-related illness. There are several companies out there. My favorite is Allotest and my Mycolab. The difference between these two companies is Allotest checks for immune reactions against the molds, whereas my Mycolab checks for immune reactions against the toxins themselves, the mold toxins. I found that my Mycolab is far more specific because you're actually now seeing, has this person encountered the mold toxins? So it is a superior test. It is more expensive. And I find that in young children, let's say 5 years old, 6 years old, their immunological response to the mold toxins is not always as good as the adults. So sometimes you get results that don't look terrible, but the exposure is significant. Whereas it appears that the immune reaction against the molds is actually more accurate of a reflection of what's going on. But again, I think my Mycolab is a fantastic test, and I would recommend it to anyone who is interested, with Allotest being another option. For people who are of limited funds, Allotest, if a provider works directly with the company, can actually do individual antibodies. So you can get IgG antibodies against Aspergillus, Penicillium, Stachybotrys for $10 each. So for $30, $40, you can actually run this test and get a relatively accurate read. I don't use Quest or LabCorp, even though they offer these testing. Insurance doesn't always cover it. And if it's not covered, it's like a $400 or $500 test. And their accuracy, I don't believe, is as good as these other labs. What else should these children be tested for? So I believe that all children who may have this need to have basic testing. There are times that these children are severely anemic and you can't treat them until you treat the anemia. Some of these children have liver enzyme elevations. They have other electrolyte abnormalities. They have frank thyroiditis. These are things that need to be checked all the time. An anti-nuclear antibody, the ANA, which is basically a check to see if the immune system has turned on the body, so it's attacking self, I think is a useful tool. Is it highly sensitive? No. But one of the things that I believe we get from this data is the higher the ANA, the more likely you have more significant gastrointestinal disruption, which also gives you an idea of how much work you have to do to get things to be in good order. I check all these children for at least thyroid peroxidase antibodies. Some people do thyroglobulin as well. Why? 20% of these kids who have been exposed have some degree of antibody reaction against their thyroid, and a handful of that, 20% of those 10 to 20%, have frank thyroiditis, and these kids need to be taken care of and have their thyroids rebalanced. Iron studies, zinc studies are very important. So I do iron panels on all the kids. I believe the children should have RBC zinc. Some people prefer to do serum zinc to copper ratios. That's fine. I check these kids for gliadin, IgG, and IgA. Why? Not just to check for celiac. It turns out, and if you go to Substack and you click on this link, it turns out that Candida actually looks very similar immunologically to gliadin. And there are several studies out there that are looking at what we call celiac may actually be a Candida problem. So while checking for celiac and ruling out celiac, what we're also able to do is when you see these marginal elevations of these gliadin, IgG, or IgAs, you're actually able to surmise if there's some degree of fungal dysbiosis that's there. Two other tests that I think are very helpful are these Saccharomyces cerevisiae antibodies. Again, when you go and look into the rich literature, first of all, Saccharomyces cerevisiae is a yeast. So what the hell would cause the immune system to react to a yeast? Well, first, you have to have gastrointestinal disruption, right? And if you look at what inflammatory bowel disease is disruption of the gastrointestinal tract lining, right? And not always do you see levels that are high enough to suggest inflammatory bowel disease. But what you'll see is if the reference point, for instance, with Quest is less than 20, you'll see a level that's 35, 40. Not enough where a gastroenterologist would get excited, but that is telling you there's compromise of the intestinal barrier, there's inflammation in the gastrointestinal tract, and some type of fungus or yeast is triggering it. And what you see is, again, several studies looking at how Candida is a immunogen, meaning it looks so similar to Saccharomyces cerevisiae that the immune system is reacting to the Candida, even though the lab thinks or is saying it's Saccharomyces cerevisiae. So we're also able to essentially gauge is there some kind of fungal imbalance that's within the gut through standard testing that's available through the regular lab. Another test that I have found to be really helpful is matrix metalloproteinase 9. Dr. Shoemaker was the first person to turn us onto this. If you ask, well, what does this MMP9 do? When elevated, it suggests damage of or compromise of the tissue matrix, especially within the gut. So if there is tissue repair taking place because something has damaged the tissue, and again, the gut is the primary place, MMP9 becomes elevated. So it gives you an idea of how much disruption there is within the gastrointestinal tract. And what I have typically found is those children that have levels above 550 to 600, those are the kids who are typically the most uber sensitive. These are the kids that don't do well with itraconazole. They don't do well with nystatin early on. They need additional support to heal their guts. These are the kids that tend to be most dysregulated. And while none of these are specific for mold related toxicity, again, if you plug all of this in, the child has all of those clinical findings plus some of this, you could make a decent argument that this may be mold related toxicity. And one of the last thing is to check for parasites. The company that I've come to like the most is this company called Para Wellness Research. They're very good at picking up parasites and they find parasites when other companies don't. Ultimately, you and your provider should be the ones looking at this. So, what about the environment? Not always is the exposure happening in the current home. And this is where the history becomes very important. The children who are doing really well and then around 3 years of age suddenly start falling apart. And then you ask, well, what happened? Oh, yeah, we moved. Or, yeah, my kid went to this school and they did have leaks in that school. The daycare or preschool was a really old church or a really old school. And yeah, I did see water stains. And that's when everything kind of started changing. You need to put the history together to understand where the exposure is to then direct the right resources to understand what's going on. Again, there are multiple different companies out there that are helpful. Conventional testing. So for those families that hire a random inspector that comes and takes one or two samples from inside the environment and then compares it to the garden outside, those are highly unreliable. And if you go to Substack, you can click on this link. It'll take you to a full discussion around that. There are multiple other ways to assess. There are ERMIs through different companies. Dust test is what I suggest. And through ISEAI, there's a remarkable list of providers who can also help, where the families can talk to these providers for $300 or so an hour. They can get someone, an expert who's really good, that can actually guide them in doing the testing and interpreting the results to figure out how much exposure there is or not. Diet. You can't heal a child, or I should say, it's very difficult to heal a child if their diet is awful. At the very, very least, and I know some of these kids are highly sensitive and they're very picky, and you can't change everything. You can't take them off gluten, dairy, doing all of these things. At the very least, these children should not be on simple carbs. They should not be getting refined sugar. They shouldn't be getting processed foods. They shouldn't be getting food colorings. The other thing is high histamine foods. And these are a list of high histamine foods: dried cheeses, dried fruits, bone broth, processed meats, avocados are all high histamine foods. So a lot of times families inadvertently think, well, God, bone broth is so healing for my child's gut and my child has gut issues, so I'm going to just give them bone broth every day. And then they're having sleep issues and sensory issues and anxiety, and they can't understand why. These are simple, simple things to address at the very least. And then if you can take it a step further and reduce or eliminate gluten, dairy, people would argue corn and soy as well, great. But at the very, very least, start with these easy to change foods that can reduce that inflammatory response. So how do we reduce inflammation? Simple protocol. And the Substack post has all the dosing and everything around it. There's a product called Miraca, and the details of what it does is in that. But basically, Miraca stabilizes the mast cells and reduces microglial activation. There is an enzyme that is naturally found in the body called the DAO enzyme, diamine oxidase enzyme. Histamine Digest through Seeking Health is one of many companies that has that. When there's inflammation in the gut, these DAO enzymes become inactivated. They are degraded in their ability to break down histamine, which causes excess histamine in the gut, which causes a cascade of inflammatory events within the gut traveling into the nervous system. By adding these enzymes in the gut, we're reducing the inflammatory response in the gut, reducing histamine levels in the gut, and thus also affecting the nervous system. Some vitamin D with K, some zinc. Important thing is that none of these supplements should have any kind of citric acid. If there is some kind of citric acid in any of the supplements, American Histamine Digest do not have it, but some forms of zinc have citric acid. There shouldn't be any added um, like colorings, anything like that. So if it is, switch to one that does. And again, the Substack has links of certain products you can find online, no financial affiliation with them. If the child also has hypotonia, they're exhausted, they're tired, they're low tone, carnitine is one additional thing that's helpful because carnitine does not activate the nervous system the same way as the B vitamins and other mitochondrial supports. For this initial phase, it's something that's helpful that can move the needle. If it works, and again, you see there's no GABA, there's no L-theanine, there's no magnesium. If you need to use magnesium to help your child have bowel movements, fine. But without causing or adding any sedative, what we're looking for is to see if the child's immune system responds. So it's almost like you're doing a dance and you're learning about this child's immune system. You're learning about how this child's body responds. 20 or 30% of the time, there's a remarkable improvement. And I put 20 or 30% reduction. So if you average it out amongst all the kids, there's a 20 or 30% improvement. But there's a subset of children that will have a borderline miraculous result: sensory issues, sleep issues, anxiety, aggression, irritability, pickiness, all calm down. Those are the kids that likely have a very stable immune system. The likelihood of big exposures in their environment are very low, and that's essentially a green light for you to start moving on. And the likelihood of having a poor reaction to nystatin and ultimately itraconazole is very low. The children who have an adverse reaction, and typically it's to Mirica, some of them have it to the DAO enzyme, and that's predominantly because they have significant adrenal imbalances. Those are the kids that have a very unstable immune system. And those are the kids that typically still have some kind of ongoing exposure. They're eating some foods that they shouldn't. There's something irking their immune system, either internally or externally. And you need to understand what that is before marching forward. Additional things that could be helpful: lithium. So for those kids that are drinking reverse osmosis water, they have lithium deficiency oftentimes, and that can cause a problem with their GABA receptors. Magnesium threonate is a specific form of magnesium that can work wonders in these kids. And then from there, you can add other things like nystatin. I didn't include it in the larger protocol, but the SBIs, so these are immunoglobulins that prevent the endotoxins from going into the gastrointestinal tract. They reduce gut inflammation, they improve gut permeability, meaning they start sealing the gut. They're fantastic supplements that are generally very well tolerated. I would add to this also zeolite clay is something worth considering. Zeolite is thought to be a binder. It turns out zeolite is a powerful antioxidant and anti-inflammatory in the gut and can also be used in conjunction. If everything is going well, that's when itraconazole, I believe, should be introduced. You have the child tolerate nystatin for 4 weeks. If the child is doing well with that, then you start bringing in itraconazole and you see one dose for the first few weeks, every few days. And then if doing well, increase to every other day. And the Detailed explanation of why we do this is in the itraconazole presentation referenced earlier. I generally keep these kids on itraconazole for at least 4 to 6 months, and very important right here, it is strongly advised to have a child checked for their liver enzymes, and I would argue a CBC with that 6 to 8 weeks after being on itraconazole every other day to make sure we're not causing harm. At times, you can get liver enzyme elevations, you can get changes in other areas. Those are oftentimes the children who look more fatigued. They're just run down, they're more irritable, they're not happy. And those are the kids that you need to pay extra attention to. Afterwards, if the child is doing extremely well, I would say it's optional, but ideal to have liver enzymes checked every few months thereafter. And you see that this is a different approach to checking liver enzymes every 2 to 4 weeks. And the reason for that is because we're not doing the high doses, we're not doing daily doses, so the likelihood of toxicity is even less. When the inflammatory response is controlled, again, I find that is the perfect time to start bringing in all of these other wonderful therapies and supports. Children that are inflamed don't always do well with even fish oils, whereas once the inflammation is improved, the fish oils are better tolerated. And how do you know this is working? How you know it's working is you see a significant reduction in the microglial mast cell reactivity. And how does that show up? Sensory issues improved. These children are more comfortable in the world. They're more comfortable in their environments. They're not overwhelmed as easily. Anxiety and the fear response. So that irrational fear response where they were getting overwhelmed, they see a little bug and they freak out, or anything causes them to get upset, calms down. The rigidity, which is oftentimes tied to that fear response, also calms down. So they're more flexible, they're more amendable, they're more easygoing. You change one little thing, they don't fall apart, they don't start crying, they don't start getting irritated. Aggression and irritability improve. The sociability improves. And sometimes the sociability is not just because the sensory issues have calmed down. What I oftentimes find is these children become way more connected. And that's because the microglial activation disrupts serotonin, it disrupts dopamine, it disrupts serotonin and oxytocin. And this combination changes how human beings socialize. So as this inflammation is calming down, sociability, eye contact, the children going up and playing with others, the children's desire to leave the house and go to school, all change. Sleep cycles can improve. So these children fall asleep more easily, they stay asleep. Uh, Digestive problems improve. Why? Because you're also changing the gut response, right? You're changing the integrity and health within the gut. So chronic diarrhea usually goes away. The chronic constipation improves significantly. And sometimes the food aversions improve. So these children that were only eating a handful of things, slowly, sometimes it takes longer, they start becoming more amendable. Now they're eating a bite of broccoli, they're eating a bite of salmon, they're eating chicken for the first time. And that is a sign that they're going in the right direction. Now, what happens after the 4 to 6 months? I typically, depending on the child, stop it. But I also tell the family to pay very close attention to what happens 4 weeks later. Rarely do you see an immediate regression coming off itraconazole. Usually what happens is the child looks fine, the child looks fine, the child looks fine. And if they are to regress, it shows up 4 to 6 weeks later. Why? Because that's how long it takes for the anti-inflammatory effects to wash away. So what I tell the families is take a very close account of everything. How well is your child socializing? How well are they going to sleep? How well are they pooping? How well are they eating? Et cetera, et cetera. What is the feedback from the teachers? How's their hyperactivity, attention, focus, et cetera? And then 4 to 6 weeks later, go back to that same detailed account and look to see if there's been any change. If the child is starting to regress, chances are there is more work to be done. And that's it. There have been so many beautiful children who I have seen light up in the world through this protocol, literally just through this protocol. The only thing that wasn't included as part of this discussion are the peptides, which aren't always necessary. But one of the things that I have found is just with this simple protocol, autistic children that were disconnected in the world over the course of this 4 to 6 months, sometimes sooner, start making eye contact, start wanting to engage with others. The children with PANS and PANDAS, the extreme fear response, the aggression, the irritability, the anxiety transform. And why I've shared this presentation and shared this protocol is because I want families everywhere to be able to access this. Again, this needs to be done with a provider that is comfortable and able to provide this care. But there are many wonderful providers out there that are able to and willing to. And for you providers that are out there, I hope that this empowers you to feel comfortable to say, I can do this, because you can. It doesn't have to be complicated. I believe we have made mold related medicine way too complicated, way too complicated. We have created too many protocols, and you've got to do this, and you've got to bring in 15 herbs and then do this and then support that. And you see there's no liver support here. There none of the things that are parts of the protocols that are out there is part of this. Why? Because over time, I found that they're not necessary. And if you address these core things, you address the environment, you address the diet, you address the gut through very simple things, you will find that these kids will thrive. It doesn't have to be complicated. It doesn't have to be expensive. It doesn't have to be out of the reach. And with even standard conventional lab tests, you can get a lot of information that can help you see if this is a child that would benefit. And with easy to prescribe pharmaceuticals, you can make a world of difference. And in 6 months, the changes you will see in these children will be striking. I hope this presentation gets into the hands of all the families and all the providers who want to help these families. Because at the end of the day, we need this kind of tectonic shift where hundreds, if not thousands of providers are saying, you know what, I could do this, and you can. There's nothing crazy about this protocol. There's nothing extremely dangerous about this protocol. And when you just look at the mechanisms and you look at what's going on, and this is meant to be complemented by the itraconazole deep dive, you see it just makes sense. It makes logical sense in terms of what is going on in these kids and why this protocol could be so helpful in making a difference for them. So with that, I thank you for your time and attention. And I hope that this really helps so many of the kids out there who are struggling. You all be well. This is Dr. K.